so much misinformation and so much bro science, and doctors don't know what's going on.
Hi, welcome to Balance My Hormones video. We're here with Pete, who's got his own YouTube channel, his own sort of social media following. It's in TRT, men's health, sort of providing helpful information amongst, a lot of information or misinformation that's out there. So, hi Pete, thanks for coming on. So what about vitamins and supplements to complement TRT? Do you take any, what do you take? What have you got going on?
I take vitamin D, D3, 500 IUs. I take Narindian, which is to help lower the red blood cell count. I'm not sure. I've never gotten tested before and after taking that, so I can't say that it works. And if you're watching this is not medical advice for me. I'm not a doctor. It's just a random guy on YouTube.
Yeah.
But I take that. I just started taking calcium D-glucarate, and a lot of people recommended that for estrogen. I don't really get high estrogen symptoms. It doesn't really affect me too much. I know a lot of people do. So actually, last Thursday, I stopped taking Arimidex and just started taking the calcium D-glucarate. I'm going to go for 2 weeks and just see what happens. And I'm probably not the best test subject because I don't really have too much issues when my estrogen gets higher, but I know a lot of men do. And so do a little test, see what happens. And I take multivitamins, fish oil, just normal stuff. I was actually interested in what are your guys' thoughts on different vitamins, or which ones do you like, dislike?
Yeah, I mean, I take vitamin D3. I actually need to take about 10,000 IUs to get my levels into any sort of good place. Vitamin K2 with it, I believe that's key to sort of get calcium out of the blood vessels into the bones. I believe that's the basis of it. Magnesium, I take magnesium at like a bisglycinate magnesium because apparently, I went quite high on the vitamin D for a while, and I believe that can deplete magnesium, and actually I noticed an increase in blood pressure. And then took magnesium, which actually it dropped by like 15 points systolic. So that's interesting. I was reading up on that. So I take magnesium. I take vitamin C, sort of high dose vitamin C, and like a good methyl B vitamin complex, basically. What about you?
Yeah, vitamin D3, probably about 5,000 IU per day, K2, and what else am I on? I've tried the calcium D-glucarate for a while. When I was in America, I bought some of that, but I don't use that anymore. Some fish oils, a multivitamin, sometimes some selenium, and zinc citrate can also act as a way to help clear some of the estradiol. I wouldn't know, maybe like a mild aromatase inhibitor, but so occasionally I take some vitamin from zinc. What I find personally, I'm not sure if everyone else finds, is I've seen something in the literature, too much zinc without enough copper to balance it can throw down your HDL a little bit. So
yeah, I know lots of the ZMA type supplements, they often add a bit of copper in if you're having high levels of zinc. Yeah, I noticed that, so maybe that's why.
So
yeah. Yeah, not much else really, I don't think.
What are your guys' thoughts on the test boosters? The test boosters being sold, are they advertising like crazy in the UK?
Well, I tried them all before I started TRT. I was in.
Well, I've heard from some patients, clients that they think the reason why the levels are so low because they took this test booster before. They may have been laced with some steroid or something that they shouldn't have had. It may well have been. We don't always know how regulated the over-the-counter markets for these boosters are, but I don't think that that's effective. There's some people say I try the tribulus or I try the horny goat weed,
ashwagandha.
Yeah.
Those are adaptogens. They may be a short-term benefit, but I don't think it's enough to live off of to boost your testosterone and just certain kind of daily activities, removing stress, your testosterone may fluctuate. They even say you get a short-term boost after you win at something. Your testosterone can rise, but again, there's that going to be sustainable and enough to keep you going. And I think there's so many different factors of why your testosterone may be low in the first place, but boosting it doesn't. I don't think it has a massive difference.
I tried to look as much evidence as I could when I was taking these things, and I tried most of them before actually getting help. And some studies that were done, I think might have shown a slight increase for a period of time, but whether it was negotiable whether that was just a normal fluctuation, you know, in the body. That was sort of the tribulus, the fenugreek, like the maca, you know, all of those types of one. Some of them, I think, can have like a dopamine type effect, which can improve sex drive and mood, or make you feel a bit hornier. But necessarily whether that increases testosterone or not, I think, is debatable from what I've read. The adaptogens and stuff, though, like the ashwagandha and like rhodiola, there's some of those other ones that are sort of the, can never say it, but Ayurvedic sort of medicine. That was really Bristolian. I think they can have some things that help with sort of stress tolerance and things like that. So maybe if, I don't know, if chronic stress or you know, I know there's a link between sort of high stress through high endurance exercise or long distance and stuff. You know, I think Russ Scala and stuff did some studies on athletes initially and their testosterone levels, and it was maybe attributed to that high sort of chronic stress. But I wonder whether maybe some of those, I mean, ashwagandha is quite well studied if you look at the sort of PubMed and see the number of things out there, but whether it's going to raise testosterone, you know, I don't know. So
yeah, I was asking what your guys' thoughts are, because it's marketed heavily in the US.
Yeah.
There's one testosterone booster that's shown in the literature to work very well, and that's clinically evidenced through fertility clinics or TRT clinics, and it's been published in the Urology Times, I believe, is clomiphene citrate, of which contains about 70% N-clomiphene, which was a drug they tried to get approved called Androxyl years ago, but didn't reach the endpoints for approval in the US and in Europe. But clomiphene in some people who have an intact pituitary, who may have never tried testosterone in the first place. I mean, we've clearly seen patients either coming to us from other doctors or being treated in the clinic through our doctor, an increase in their testosterone being boosted, if you will. So it's a way to boost endogenous levels without shutting down one's pituitary axis. So that has shown to be effective. The question is whether people feel subjectively better with that treatment, or do they feel better with testosterone treatment? And I think that's individual up to the patient.
It's usually lower dose, isn't it, in comparison to like where clomid is used in post-cycle therapy with bodybuilders and high dosages. It's usually like at least a quarter of that dose, I believe.
Yeah, in the US, clomid is prescribed a good amount. It's usually a lot of doctors, if they're not comfortable prescribing testosterone, they'll start with clomid, usually 25 or 50 milligrams every other day. I mean, it depends on the doctor, but I've seen mixed results. I've seen a lot of men say that it got them up to 500-600 and they felt better. I've seen people say it got them to 500-600, they didn't feel better. Mm-hmm. The only thing that worries me about clomid is the visual side effects. People see the floaters and stuff like that, but I've taken clomid before. I didn't have any issues with it, but I have seen some men that do.
I suppose, like, in my mind, if like I'd rather have a bioidentical hormone than
another substance.
Yeah,
it's a selective estrogen receptor modulator. So on the opposite side of the SARMs, which are selective, and so I know eventually the pharmaceutical companies will probably push for SARMs, and that's how they'll get back into the hormone market, is by finding some patent on a unique molecule that will, act like testosterone, but have all the best bits without any of the bad bits. And so that could be our future. So that wouldn't be bioidentical, because essentially it's just playing around with the androgen receptor as the SERMs do with the estrogen receptor.
Yeah,
that brings us to our next thing, is SARMs. SARMs are pretty interesting, and like you said, clomid is a SERM, and there's lots of SARMs on the market. And for anyone watching, SARMs, 99% of them are not approved. They're just for testing, medical testing. But it's just interesting that a lot of them go in and just target certain androgen receptors, and maybe at one point we'll find one that could do what TRT does.
Yeah.
Yeah.
I don't know how to give up my testosterone in place of a SARM. I mean, logically, yes, if the testosterone's activating all your androgen receptors, what's the difference if another chemical's doing it? You're kind of fooling the body. But I think the fear is you may not get the metabolites that you want. Now, that is supposed to be the benefit of the SARM, is that the metabolites, DHT and estradiol, won't be there in any great quantities. So therefore, the SARM will give you the best of both worlds, but I don't know, maybe we'd have to add in estrogen as well as DHT.
Yeah, but that's, you know, the benefit of TRT and having testosterone is its metabolites as well, right? So it's,
yeah, well, I agree.
Yeah. I think they're looking at a couple for sort of breast cancer and things like that at the moment, and obviously, you know, bone density, osteoporosis, muscle wasting diseases, and things like that. But I just don't think they've been around a while. But I don't think they're at a point where, you know, it's going to be able to replace anything yet. And like I say, they don't convert to estrogen. So where would men get their estrogen from? You know, where DHT and things like that. So
I mean,
yeah, I wonder.
Unless a particular SARM could fool the body not to switch off its own production, and then you would just top it up with this SARM to activate the receptor, then that would be the only place where you would get the estrogen from your own body's production of testosterone. So
I suppose, I mean, if you're doing TRT, I mean, why are you replacing TRT? I mean, TRT provides you with your testosterone, right? I suppose it's when maybe you get into the realms of elderly people or women or children or muscle wasting diseases or neurological conditions, that maybe that's where they want to, you know, benefit from increased anabolic nature of a drug without increasing the dose of, like, you know, to get the anabolic effect of testosterone, you'd have to go way up, then you're going to get all the androgenic side effects. And I know this is why the anabolic steroids were sort of created, was the aim to try different,
for women with breast cancer, you know, for muscle wasting.
So I think they're just trying to, you know, find more fine-tuned versions of those to be used in those types of things. I mean, I'm not sure whether it will cross over into TRT. It'll be interesting.
Yeah, I mean,
I think I'm talking like future. I mean, most of the SARMs that are out right now are pretty much, you know, they're androgen receptors, and people use them to get bigger and stronger, but a lot of them are still suppressive to the, you know, the body's natural production. It's interesting when you said, you know, testosterone, you know, part of it was created to help women with breast cancer. And it's interesting that so is arimidex, and a lot of the aromatase inhibitors. You know, a lot of these cancers in our body, when they use things to suppress hormones to help treat that cancer.
Yep.
I find that just interesting on how everything's interconnected in the body.
Well, just like DHT inhibitors, finasteride was developed to block the enlargement of the prostate and even prostate cancer, and then they find that it also helps with hair loss. Obviously, I don't use finasteride, but I did. But I know what I want to, because of the horror stories that you hear of people that do use finasteride or get the finasteride syndrome. So there's, you know, always a downside to sometimes blocking things that are more natural to the body. But you know, some people do use finasteride, you know, either with the testosterone or without, and they can be fine. But I wouldn't touch it.
Yeah, I wouldn't.
But that's on my personal experience.
Yeah, I've heard issues with finasteride and cabergoline. I've heard those are two medicines that can have a lot of side effects, or serious ones.
Well, what have you heard about cabergoline? Because cabergoline, caber can be used it can be very helpful for men who have hyperprolactinomas, and you know, it's a lot safer than having surgery, you know, because so that's really kind of saves them. But you know, bodybuilders abuse caber. You can overly suppress your prolactin levels, and you need to have a healthy level of prolactin. So I think that's where maybe the danger comes from.
I think the studies that showed issues with the heart and things like that with cabergoline were
Parkinson's patients,
very high dose. And I think some of the other sort of dopamine agonists like bromocriptine and pramipexole, they're not the same, are they? They're two different.
No,
ones,
bromocriptine is more similar to caber, and then pramipexole is a dopamine agonist, a direct dopamine agonist that's used for restless leg syndrome and Parkinson's.
Right. I think some of those can have some, like, if you withdraw from them, you can have dopamine withdrawal syndrome, and some of those older ones can be a little bit more difficult. But I know cabergoline can be used sort of low dose
once
for
a
guys.
Month, once a fortnight.
Yeah, with high prolactin.
Every 3 weeks.
Interesting. Yeah, I'm not too well versed in cabergoline. I was just I just remember hearing that it could have some serious side effects, but I didn't dive into it that deep.
Yeah, and some of those studies some of the studies in on the heart valve were also shown to correlate that you'd have a similar effect if you had high blood pressure over time, as far as the valve prolapse or relapse. Or the mitral valve tenting, I think it was. That was similar to patients that had long-term high blood pressure. So.
Okay.
Interesting.
Okay, thanks Pete for coming on and joining us. I know we'll do a few other videos. It's just about sharing some information with guys and trying to be helpful. So thanks again. Obviously you can check out Pete's YouTube channel.
YouTube channel is Test Your Levels. I want to thank you guys for talking to me as well, because we do this every day, whereas I just do research and make kind of somewhat funny videos here and there. But it's really interesting hearing all your insights and knowledge. So that's really cool. I appreciate the time taken out of your day.
No worries.
Thanks for good.
So yeah, our YouTube channel, just Balance My Hormones YouTube channel, if you want to check that out. But
EU, TRT UK.
Yeah.
And we'll also put a link to Pete's channel in this video. So subscribe to both our channels. If you like the video, please like it, and if you don't like it, you can hit dislike.
Yeah.
But we'll be at like.
Yeah, and subscribe. Yeah.
Don't forget, check out the description. Click on the subscribe button, both our channels, get your levels tested, and I'm glad that making friends in the TRT community. I think we all need to stick together.
I agree.
It's a very serious thing, and I think it's starting to come to light, and I hope it becomes more mainstream, and that stigma of scary testosterone slowly goes away over time.
I think it'll happen if we all work together, all of us in the field, rather than fighting each other, that we all come to consensus that all we're trying to do is help men and women have access to these hormones when they've been denied before.
I think with all the birth control and SSRIs floating around in the water, I think there's going to be plenty of TRT patients for everyone.
Yeah, I think so.
Exactly.
All right, well, thanks.
Pete.
Yeah, thanks very much.
Yeah. Thank you guys. Have a good one.
All right, see ya.